The Board of Health will come to order. Do we have any members of the public online or in the room who would like to address the board?
Behind you. Morning.
Good morning, board members and ladies and gentlemen. My name is Jeff Kettleson and I live in Billings here. And I'd like to thank the board for the fine work that you've done and you're going to do in the future. I believe that the board has been proactive instead of reactive, and for that, as a citizen, I thank you very much for your service. The reason that I came this morning was to say that currently right now, there's 5 states in the United States, maybe 6, not positive, that allow ivermectin for sale over the counter. There's approximately another 10 states that currently have it in their legislature to also allow it over the counter. In Montana, we don't allow that. So I'm presenting stuff to the board and to maybe have you consider throwing your weight behind that. I don't see any downside to it. And I think that it would benefit the citizens of Yellowstone County. And to tell you the truth, we're kind of tired of going over to the feed store and buying our ivermectin. So anyways, thank you very much for your time. I hope you have a great day.
Thanks for your input.
Thank you, sir.
What is, John, what is it?
It's a veterinary field that there's needs to be more research, the impact and effectiveness on certain viral conditions. I think that's something that the legislature has to have a conversation about.
It's outlawed in the state of Montana.
No, it's not available in county. Need a prescription.
Okay.
All right, can I get a motion to approve our January 26th, 2022 meeting notes?
Thanks, Coach. The second.
Second. Thanks, Gary. All in favor?
Aye.
Opposed, same sign. That's approved. Now, your report, please.
All right, good morning, board. Eric and I had the chance to head to Washington, D.C. 2 weeks ago now, during the week of February 8th to the 12th. Right before we departed for Washington, had the opportunity to share with the policy committee that Congress approved the Consolidated Appropriations Act. And within that act was the very first increase for a community health center in a decade. So we got a little bit of a bump for community health center funding federally. We also received in that Consolidated Appropriations Act $350 million in base funding for the National Health Service Corps across the country, $225 million, which will go up to $300 million in year 4 for teaching health center funding. A reminder, we were one of the first 11 teaching health centers in the nation and still maintain the Montana Family Medicine Residency Program. Because of that program, I sit on the National THC GME board for the National Association of Community Health Centers. And so we were able to advocate and get, for the first time ever, multi-year funding for that teaching health center program. So 4 years of funds, which helps sustain our 3-year residency programs across the country, of which we have one. That's important because as our residents come out of medical school, they look for placement. They want to know that the place that they're going residency sustainably funded and isn't going to just close halfway through their residency program. And so that's what we were telling, the story we were telling Congress, and they listened. So that's a positive, maybe a first. Extension of Medicare telehealth flexibilities too. We were able to get Medicare to approve all of the telehealth flexibilities that we've been fighting for since the pandemic through the end of 2027. So that will be good news for seniors across rural and frontier Montana. Had the opportunity there to share some photos with you. We obviously went to Montana Coffee while we were there, but also provided Senator Daines with Community Health Center Advocate Award. This is presented by NAC to senators and representatives who sign on to the Community Health Center appropriations bill every year. And so Senator Daines has always been a supporter of community health centers across Montana. And so we were able to present him with that award. And we met with the rest of our delegation, had some good conversations with staffers, as well as Representative Zinke. And then we met with Representative Downing while he was back in the state on Friday. He had gotten called to a meeting at the White House while we were on the Hill, so we missed him then. I got to hear RFK and his opportunities to continue making America healthy again. Community health centers are, again, the backbone of the MAHA movement. They exist to support ending chronic disease, to support improving food as medicine programs and dietary outcomes. And so the work that we do is vital to that movement and vital to doing it right. So we'll continue to do what we do best. Got to hear from good old Bernie. Senator Sanders was there evangelizing about the work that we do in healthcare. And then Dr. Raj showed up as well. And I had the opportunity to chat with Tom Engels, the HRSA administrator. So HRSA oversees the Federal Health Center program. Got to chat with him and Jim McCray after their session in the opening session. And Jim McCray invited Tom to Montana. And Tom said that he would work it into his schedule sometime in 26 or 27 to get out to the state. So that would be great if we could get the HRSA administrator here to see what we do, to see the difference we make in the state of Montana. And so we're going to continue pushing for that. Overall, good visit. Anything I missed, Eric?
Nope, I think you covered it.
Cool. We made a selection for our next communications and marketing director, Brianna Treaton, was internally from the Eastern Montana AHEC, where she also oversaw the Montana AIDS Education and Training Center. She knows RiverStone Health, she knows Yellowstone County, and she knows communications and marketing. So I think she'll be a great fit. And I'll have her here at a future board meeting so she can introduce herself. And you can see who she is. Next time I'll include a picture. But before joining RiverStone, she was in marketing and PR at a community bank. She's also had experience in the nonprofit world, higher education, and the political world while she was down in Florida. So she brings a good experience to the role. We held our ribbon cutting last Friday for our health center at MRM. So our healthcare for the homeless clinic is now open and seeing patients. Being that one-stop shop right there on the campus of MRM has been really beneficial to the patients and to our unhoused neighbors who are coming to that campus for help. So that's been a really good add to what we do and good centralization of services. There is, speaking of policy, a new House bill. It's HR 7391. It's sponsored by General Birdman. He's a Republican out of Michigan. And it's co-sponsored by Jake Auchincloss out of Massachusetts. And that is to protect 340B for community health centers and exempt community health centers from any future CMS, HHS pilot programs if they choose to try to change or adapt the 340B program at the federal level. This one, we were able to bring it up at our meeting with Ryan Zinke, and his first words out of his mouth was, well, what's the OMB score? How much is it going to cost the federal government? We were able to say $0, sir. And he said, those are the kind of bills I like to sponsor. So he knows General Bergman pretty well. They're in the vet caucus together. And so I think we might even be able to get some Montana support for this bill at the federal level. Again, our MedStart and Heads Up camps, our applications are open. So if you know students who are interested in healthcare careers, if you know students who are interested in behavioral health careers, there is a summer camp for those kids here in Billings. You can attend in Billings. There will be an opportunity to attend one in Bozeman. And I think there's one more spot in MedStart across the state. But we bring the kids here, provide them with housing, give them a week-long intensive engagement with our entire healthcare infrastructure. So they get to come here, go up the street to the hospitals, learn about healthcare careers, maybe even take a ride on a helicopter, and get to see what it's like to be exposed to future healthcare.
What ages are they?
It is middle school to high school.
Are we providing that for free now?
There are scholarships
There are
available that we can provide. Yes.
And School District 2 now has a coordinator that just started who is helping students find med careers.
Yes. And as SD2 looks to expand their high school career offerings for healthcare, we have a seat at that table, and we're working with SD2 to figure out how we not only include healthcare careers, dental careers, behavioral health, but also public health exposure. So we are one of 3 health departments in the state that is working with the University of Montana right now to build out academic health departments. And not only is that going to be academic for research for graduate students and undergrads at but it's going to mean connecting with local school districts and schools, working with the HOSA coordinators right now to get into Billings Central and SD2 and the Career Center to expose kids to Public Health 101. What is it that we do really versus what you think we do? And healthcare, CMAs, CNAs, PAs, NPs, different pathways that students could take. So I think it's going to be a really good opportunity. Friday, February 6th, the Colonial Apartments were finally cleared of all remaining residents and squatters as the formal eviction proceedings closed. We still have not taken ownership of that property. It's still under the ownership of the estate and the responsibility of the state. And so the responsibility lies with the daughter and the co-owners to make sure that residents maintain their access to their personal items if anything is left behind. Next week, it looks like the contractor will be starting asbestos abatement and getting the facility ready for whatever comes next. So we'll continue to keep y'all updated and monitor the progress there.
Has it been fenced yet?
It is, yes. It's completely fenced and secured, fully boarded, per the court order. The state actually had to go back and put boards on second floor windows and others due to the court order. So they're following the court's process, and we're supporting whatever we can. We supported all of the residents who were there, got them into either additional housing units or safe spot at the mission for now, and continue to work with those folks.
Great. Does any security go by day
Yes.
or night? Is it ours that goes
So,
by? Is it
Both I think all aspects of the sheriff's department wants to keep that thing as secure as possible. Billings Police wants to keep that as secure as possible. our own security guards are rounding. John Jones, who is our now campus security navigator and manager, he is rounding that building on a regular basis. So we're working to identify risks, see where new holes pop up in the fencing, respond to different things. And it's on cameras now on that side of the campus. So we at least monitor 90% of that property.
And asbestos, is that being done under the trust?
Yes.
Oh, or is that? So they're doing it.
So they're doing everything right now until we take ownership of building.
And the buildings are down, what will be there? Will we put in grass or just?
For now, if the buildings come down, it'll be, I think, gravel lot for now. And then we'll figure out what comes next. We didn't want to create a green space or a welcoming park that if we were ever to go and build on it again, people would say, well, you just created a park, so
Yeah.
why are you getting rid of a park? So we'll continue to navigate that.
This might be a meeting place too. So.
Yep. Didn't want it to be too welcoming. So we continue to seek volunteers. Next Friday, there may be a slot or two left. If anybody wants to come read to students across SD2 and our county schools, RiverStone Health is sponsoring this program, United We Read with United Way. As we get out into schools, I'll be headed out to read to a class. But we continue to talk about the connection between public health and well-being and childhood literacy and health outcomes in youth from an early age. We know there's a direct tie. We know there's a tie to reading and well-being in adulthood too. And so we're going to continue to support getting books into the hands of our kids and supporting that United We Read program. And then finally, for you, the protection update, flu remains high, not uncharacteristically high, remains about the 2% average we see year over year. But we are in an elevated flu status. Hospital admissions have gone down week over week, which is good. But the number of cases continue to rise. So it's still flu season, even though it feels like summer. We'll see what happens if it decides to cool up. And then finally, just a reminder, we now have our new injury and overdose dashboard posted on the website. Thanks to Taylor Cook, our epidemiologist, and the team upstairs. We will be sharing this data transparently, publicly, and regularly. And it's all available on our website now. Any additional questions about the report?
Do you have any connection with the new nursing school that's being built?
We don't, other than the connections that AHEC has with, getting nursing students in, and we get a lot of nursing students in from MSU. I don't know why we did not have a seat at that table when it was being built and discussed and put between the two hospitals. But I've made my feelings known about the lack of our involvement and engagement in that. And so hopefully we have a seat at the table going forward.
Is RiverStone Health looking candidate for National Health Service Corps employees to come in, be match funding?
We are, yes,
They
we
are
are.
that already?
We do.
Oh, you
Yeah,
did that.
yeah. We've done that probably since that program was conceived. Yes, yeah. And so that's another conversation. I could spend an hour talking about our health profession shortage area and the score that impacts the amount of money that we can get through that program. And so that number continues to flux, and we continue to fight for a higher one and talk to the federal government about why that's important. The other thing that will be important, and I should share with the board, it'll save us some time during the policy committee report, Chair, is that there's a new letter that has gone out from MHA, the Montana Hospital Association, and that Dr. Littlefield, Dr. Brand and I will be commenting on and sharing with the Department of Education because of the new federal regulations that were included in HR 1 above. The Department of Education is now seeking comments on their proposed rule that changes the professionalism status of certain careers. So it would impact a physician or a physician assistant or a nurse practitioner or a nurse, their ability, or a dentist or a hygienist's ability to get federal loan repayment by declassifying those roles as professional. And so we're gonna have some good comments back on that to the federal government to help hopefully have them reconsider their changes there.
John, as part of this National Health Service Corps funding, do you know, does that also include scholarships for folks? That is, students who qualify for some sort of competitive kind of scholarship program, then get their education paid for upfront? That used to happen. That happened to me, but
there have been National Health Service Corps scholarship, and I don't know whether they're still active, whether you can still apply for those on the HRSA website, but we did have those in the past. Do you know if we have any current scholarship recipients?
Not that I'm aware of. All the ones I'm aware of are loan repayment.
Yeah.
okay.
So, but that is available. And so if you do get one of those scholarships, then you have to commit to a minimum of 2 years and a 4-year max of full-time service in a designated profession shortage area.
Mm-hmm.
So that's been a conversation we've been trying to have with RVU and Turo. You have all heard it before. We have a 450% increase in the number of learners now that are saturating our state, but yet we've only had a 25% increase in the number of preceptors and open slots that are available to train all of these residents. There's a few problems there. One, that's a big gap to try to overcome. 2, we have to figure out either an incentive or a model where we can attract additional folks to be preceptors and take on these students. And then 3, these unfortunate, for-profit DO institutions are really expensive and they're really cost prohibitive for students from Montana. And so what we're seeing is a promise made for all of these students to come from Montana, Wyoming, the Mountain West, and be homegrown, but yet they're not able to afford schooling at those institutions. And their students are coming from out of state, California, Texas, all over the United States, to be trained here in Montana for 4 years. And because they're so expensive and cost prohibitive, students coming out of those schools in massive debt are not choosing family medicine because reimbursement as a family medicine practitioner ain't the greatest thing in the world. And so it's just a compounding issue where we're going to have to work really hard to keep these medical students interested and engaged in remaining in Montana.
Has the state had any bills where they were considering like paying people to be preceptors? Is that still in the?
We've had those conversations with legislators. I think anything that has a fiscal note attached to it is going to not make it through the 27 session. I met with the governor earlier this week and he kind of outlined what his priorities were for 27. We talked about our healthcare priorities for the upcoming session and what we'd like to see. A lot about workforce, a lot about rural health transformation. The state, because of the way last session we set up our tax code to match federal tax code, and all of the changes that happened with the big beautiful bill in HR 1, the state is now looking at, it's not just the city of Dallas paying in debt. The state is now looking at a $600 million budgetary shortfall because of how the changes happened. So we went from a budgetary surplus at the state coffer to now a budgetary deficit. So anything that costs money or adds to the state budget probably doesn't have legs this session. And so one of the things that we have talked about was some sort of tax credit, a preceptor tax credit. It's not going to cost the state any additional money to, do that, but it may take money, take a little bit of money out of the state coffers. And so that'll be the give and take if we say, hey, it's not going to cost you any money. And the people that, are going to step up and qualify for this, we need them and we need them badly. So help us do this. And I don't know what the fiscal note on that would end up being.
John, do you want
In the packet, there was all the information about the rural health transformation grant.
Yes.
Isn't that an opportunity to help fund some of like preceptors and some of the other things that are
Yes.
real challenges for us?
Yes.
Okay.
Yes, and so that's our argument as the hospital association, the primary care association, and others have said, here are all of these funds now. You've got 233 million a year
Yeah.
over 5 years. The other thing the governor said was, I'm telling Charlie and DPHHS not to plant acorns. I don't want to grow big oaks that have to be pruned and taken care of for decades. I want projects that are going to be sustainable and we can start up and we can fund, and then they kind of can live on their own in perpetuity. There's a couple different things. The first year, they're going to work on infrastructure, try to put in an electronic medical record for the state hospital. It's decades overdue. They can get their Flintstone tablets gone, fizzling on right now, and they can build better. The state hospital is wasting a lot of taxpayer money by not documenting accurately and getting paid for what they're doing. So an EHR will probably help with our budgetary issues. Then they're trying to get all the systems to talk to each other. And so whether it's CHIP and Medicaid and SNAP and TAMF and WIC, or it's the Department of Labor and jobs and income tax data, we're trying to mesh all of that together so that when work requirements come out for Medicaid, which is likely this summer, they can have the systems in place where all of the state information is talking to each other, and we won't have the same snafu that we had 2 years ago where people fall off and can't get back on even though they qualify for those benefits. So the state knows that they've got a lot of work to do to create the infrastructure to support all of these programs coming down the pipe. And that's what they're going to focus on with the first year of funding from the Rural Health Transformation Program. There's been other conversations of, hey, could we do something innovative? Like, Wyoming got it approved initially. I don't know if it's going to be approved in perpetuity, but they created a rural health trust fund essentially with some of the money. And so they're trying to put some of it aside because they know they can't spend $200 million a year on, all good things. And so they said, let's put some in a fund where we raise some interest. We can generate some new innovative payment models. We can fund preceptor slots. We can do something with that money and keep it more long-term. Whether that's going to continue to be maintained by the feds is still up in the air, but they got it approved initially. So We are all open to figuring out what we can do in terms of innovating with that money before it all comes and goes.
Other questions?
A question, just to comment, congratulations on putting Rihanna to that position. I know Rihanna did well, and she's an excellent candidate. We
Great,
got a good one.
we think so.
Would you like to give the, good discussion? Thank you, everybody. Would you like to give the medical officer report?
Sure, yeah. I'm not a physician, but I did stay at a Holiday Inn Express last night. There you go. I give Dr. Littlefield is out battling illness, but she'll be back tomorrow and well on her way to recovery. So just a few things there. We continue to try to hire. We've got some vacancy savings in our budget, which we'll talk about in a bit. But we continue to try to find physicians, nurse practitioners, PAs. Good news on the PA front. We've been interviewing a few good candidates. We've hired a new FNP, and our advanced practitioner residency program for our NPs and PAs is just out there on the street, word of mouth, and applications have gone bonkers. We have more applicants than we have positions right now, and a lot of interest. And so we're going to get that coordinator position is hired internally. And we're looking to figure out how we bring residents on now within that program. So the need is there. NPs and PAs want additional education and training. And so we should be able to staff and hire those positions easily.
And how do we finance all that educating?
Funny you should ask. Well, it's a combination of patient services revenue, 340B program, and that revenue that we get from the pharmacy benefits, but also direct patient care costs. And I'll let Shanna talk more deeply about where the money's coming from.
Sounds good. Yeah, and we did a lot of modeling on this one, and so it's great to see that come through and really looking. I mean, a lot of it is patient services revenue driven, and so really took a look at a few different scenarios, kind of how to onboard and what made sense as far as what we take on initially and over the next few years, and so really self-sustaining based on patient services revenue.
We have 4 behavioral health candidates working towards licensure right now, which is great for us and our patients. 1 just passed her boards. 2 others are very close to board eligibility. And so we'll have board licensed behavioral health counselors on staff very, very soon, which is great. Continuing to train and recruit. Yesterday was the last day of new employee orientation for this cycle. And SLT always goes at the end, the last session of orientation to meet and greet our new staff. And we hired a brand new nurse supervisor for the clinic. She's been here before, and she came back because she loved working for RiverStone and missed the culture and the team that we have here. And so she's back as a nurse supervisor. But one of the things that she has done in her career, she was the MA certification trainer for Charter College before they closed. And so we've been trying and wanting to start an MA certification program here on campus for our own MAs. And I think she has the ability to help us get that going. So really happy to have her and the other employees who started this week. Continuing to recruit for the rural track. Recruitment for our residency class of 2029 is wrapping up, and match day is quickly approaching. So all good news there. And then, yeah, we could just keep on keeping on as far as clinical recruitment is concerned. We're continuing to work out the kinks behind spirometry, which helps diagnose COPD, asthma, We're offering that as a service again. And we'll continue to try to expand access to that service as staffing allows. So all good things on the clinical front. Any questions for Dr. Littlefield I can pass on?
So John, do the patients in the clinic get a written summary of their visit as they leave?
They do. They do.
But not in home care yet?
Not in home care yet.
No, they don't.
Other questions?
Just, do you know what program they use for the spirometry?
The name of the machine. I don't. Sorry, I can get that for you if you're interested.
Is that a billable service or is that just something, so the pharmacist you can bill insurance?
Yes.
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 Can't.
Yeah.
The note about space is not adequate, Joliet.
Oh, our adequate space in Joliet? Yeah. So the goalposts keep moving for Joliet. The plot of land that we've been looking at, we had to temporarily move out of the community center. So we're in the space next to the 212 Bar and Grill. It was an old barbershop salon. It's not made to be a medical clinic. It's a modular home that we're operating out of. And we're making it work because that's what you do in rural healthcare. But it's not a long-term sustainable option for us. And so we've engaged, even as soon as this week, engaged with keep laughing every time I say the city of Joliet. But the city council met in Joliet this week and they done buying the property that we worked to get them. So MDT has agreed to allow Joliet to purchase the green grassy knoll on the right hand at 212 as you go south towards Red Lodge. For a nice sum, not a whole lot of money. And we're going to figure out how we move forward there. If we have to buy it, we may just buy it if it works for us. So we need to do our due diligence. We need to get a survey done on that plot because I need to know, can we absolutely build a clinic there? There's a pipeline there. It's an old railroad right away. I need to know, can we build something there if we purchase this property and can get funding for this? So we're waiting on the town to either buy the property or tell us that we can from MDT. And then we are working with our congressional representatives who do congressionally directed spending or earmarks to say, hey, we've got a rural clinic down here in Joliet that needs to be built. Can we put in an application for some congressionally directed spending and support that program? But in order for us to do that, they want us to have the land purchased and a plot for this to go. But then the goal down there would be to build a clinic, provides continuity of services down there in family medicine, but also then add behavioral health, add dental if we could, provide some additional services down there in Joliet because the community is desiring it. It needs it. So more to come there.
Questions? Other questions? Hearing none. Mr. Cromley.
Okay, well, we had several topics we discussed at Public Policy Committee. First one was ongoing, or the beginning of the program to get rid of kratom in the community. It's voluntary compliance deadline March 30, after which there will be enforcement proceedings. I think there indicated there's been quite a bit of cooperation, but there will be some cases where there will be some resistance also, and they involve even working with the county attorney's office.
Out of 1,100 plus licensed establishments, there are 3 total entities and 4 total licenses. So one has 2 locations that are not compliant at this point. And so we sent those final letters. Everyone else who has been notified and we've worked with has let us know that they intend to comply or have already complied. And so those 4, I signed those letters and sent them out certified mail last night. And so those individuals, probably only 3 of them, the 4th one has let us know already that they do intend to comply by the deadline. The other 3 will be sent to the county attorney's office for coordination.
And then John reported on this trip to DC. Cover that.
Yep.
In your packet, we have a pretty extensive report from the state on the progress going on there with regard to the rural health transformation grants. Ongoing process with regard to the distribution of funds there. And then last we considered we had a presentation on the increasing environmental health service fees. Now, these are not license fees. The license fees are set by the legislature and there was an increase, but these are fees for additional services that may be required following up on various situations. The schedule is that before you and the committee voted unanimously to recommend that this board approve those, in most cases, increases. In some cases, there's a new division also it was before small and large. Now there's a medium division, but at this time I would move that we approve those fees.
Second.
All in favor?
Aye.
Questions? Yeah, I have a question. So back on public accommodations. So the question I have deals with, and I don't know if breakfast, rooming, or boarding house encompasses Airbnb, short-term rentals. So there are roughly 500 short-term rentals in the city of Billings that are housing people. And so
Airbnb.
Yeah, short-term rentals is really the VRBO's company. So the short-term rentals is one. So I was questioning whether, whether or not hotel, 1 to 10 rooms. It's a question that, to me, they're housing people. So they're no different than I am from that standpoint. So I guess I have no problems with approving, but I sure would like to see it addressed as a part of that.
Where does the figure, I'm curious, where does that figure come from, that 500 item?
400, I can get you the last one within the city.
So they do have a record of those? Those are.
Well, they're supposed to be licensed within the city.
Yeah.
A lot of people don't. Our people across the street aren't licensed and so.
Yeah. So
but they have, probably out of 365 days, I'll bet you they have 200 days that they have people staying at that house. So it's, the question is, what are we, as the health department, what are we going to do with it? That's.
So a lot of the environmental health stuff gets complicated because there's 3 partners involved in when you license and inspect things. There's the state, there's the city, and then there's us, right? So this is one where all 3 of those folks have to weigh in. I know that Melissa has been looking at this with the environmental health staff. They've been doing an analysis over the past few months about the cost benefit of starting to inspect those short-term stay, Airbnb, VRBO type places. And they're having some conversations with the city, licensing departments about it too. So they're looking into it.
And there's some precedent set in primarily in Flathead with, all of the short-term rentals and the issues that they've been having in Whitefish and Kalispell. And so we're working with other health departments across the state too, to figure out how have you worked through that, right? It's kind of in those more, tourist prone areas, it's become more of an issue. And they've had other problems, so we want to prevent them from happening here.
Brent, what was your motion again?
To schedule increases in service fees for the Department of Environmental Health.
Michael, second. Any other comments or questions? All in favor? Aye.
Aye.
Opposed, same sign. Passes. Anything else for public health?
No, I think not.
Approve them.
The minutes, approve the minute.
I'm sorry. Below the minutes. Second,
Warley.
all in favor?
Aye.
There was one more thing to share, based off the policy minutes that I see in here. And if Dr. Littlefield was here, she would bring it up and talk about it. So it's the childhood immunization schedule, and that there's been no changes as far as RiverStone Health is concerned, or as far as DPHHS is concerned at the state level. Childhood immunization recommendations are attached in the packet in the minutes. And the vaccine acknowledgement that we have provided and will provide, to parents to continue to make informed clinical decision making. Feds can call it whatever they want to call it, but we have been practicing informed clinical decision making for millennia, and will continue to do so. That's what public health does. That's what medical practitioners do. And so a lot of noise, a lot of political hubbub, really over nothing. There's been no changes to the schedule as far as we're concerned, and we'll continue to offer all of those vaccines to parents, and they have the ability to acknowledge, sign on and accept, or decline any of those vaccines that are on the immunization schedule.
How many of the kids, and I don't know, the universe is in the county, do we vaccinate? I mean, we 60, 70, 80, 90% of the children are vaccinated.
Yeah, I had those numbers. We're not supposed to publicly report them. I had numbers from SD2. The state stopped reporting those during the pandemic and never started again. And so we know internally, so that we can best prepare, and we all share that information across, schools and county, because it helps us understand if there is an outbreak, if there is, measles in a school, or pertussis, or chickenpox, or varicella, how we need to respond. And so when the vaccination rate is lower for a certain illness, we respond quicker and heavy, more heavy-handed, and try to get around that. It's in the high. It was in the low 90s. It's probably in the high 80s, low 90s still. But it's declining.
It would be nice to have the schedule listed other than just the vaccine.
So this is our form for parents. So we have another document that has the schedule. Yeah. outlined, but this is our informed clinical decision-making document that allows the parent to see the vaccine. We provide them with information on it, and then they can, consent to receive which vaccine.
And the fact that we're not keeping records across the state, and it's gonna drive the epidemiologists crazy. It's just rather stupid. And now we're getting polio back. Measles and pertussis and, oh, yeah, let's welcome polio. Sorry, I should shut up.
No, we had a conversation yesterday about our measles signage, and we said, yeah, sure, we can remove the measles signage for now at the front door because we don't have any active cases. But I said, thank God we're not South Carolina, because South Carolina is running rampant right now. And they are having a hell of a time getting it under control. So it's the fact that good old public health, we are victims of our own success, and we have done such a good job alleviating human suffering and illness and sickness that society feels the need for it to come back. And maybe once it comes back, when rip-roaring force, folks will see the light again and understand what we've been trying to do all along.
20-year cycle.
I know a lot of, here they're doing delayed scheduling, not necessarily not getting them, but they're delaying the schedule. Other countries.
The whole argument that, well, we should do what the Netherlands does or ex-European country does is not accounting for the healthcare infrastructure that those countries have. There are very little barriers to healthcare access in a Scandinavian country where healthcare is a human right and it is free, and it is provided in a universal system. There are way too many barriers in the United States of America, financial, transportation, otherwise, where we don't have the same rights and privileges and access to healthcare and preventative care. And so we need additional safety measures. And that's what vaccines are. They're the additional safety measures that take care of, in many cases, the systemic failures that we have at every level of government and every level of our healthcare system. And so until we try to fix those, we need these safety nets. And we can't have those conversations that, well, we ought to have the same schedule that this country has when we don't have the same healthcare system.
Very good point. Very good.
Other comments or questions? Hearing none, finance, Spencer?
We agree to do safety. I'm sorry.
Yes.
Skipping by me.
I want to
Don't take it personally.
The Safety and Quality Committee was a discussion of the use of artificial intelligence in home health, hospice, and home care. They're behind the clinic. It's much more difficult to do some of that stuff at home. They reported that at one point, sometimes with a patient, they have 400 to 600 pages of info that need to be scanned. So obviously, artificial intelligence is going to help with that. They are trying very hard to follow the guidance of the RiverStone Committee on Artificial Intelligence. They're being sure that they meet HIPAA requirements. Any questions?
Final, any comment?
No, I just want to thank Dr. Dor for stepping in. I've been suffering through 75 and 80-degree weather here in Arizona. So thank you, John.
Get a motion to, any questions for Lionel or Coach? Hearing none, can I get a motion to approve the minutes?
We approve.
Second. All in favor? Opposed, same sign.
Gonna be 60 and sunny today, Lionel. You can come home.
Okay, I am coming home. Thank you.
He claims to be en route.
Yeah, no, not yet, not yet.
Now Finance Committee. Plus, Michael, did you have a comment? Okay,
Finance Committee, so I'm gonna turn some time over to Shannon, but first, just a brief recap of what we've included in the package for you today. So we have included, this is our quarterly report, so it includes not only the RiverStone Health financial statements, which we provide to you monthly, but also includes the YHP financial statements and the RiverStone Health and YHP combined statements. So the conclusion of our presentation will ask for a vote on those, but that's what's included in the packet. I'll turn the time over to Shannon and go through the financial performance.
Thank you. Good morning, everyone. So as Spencer said, a lot of financial information in this packet. I'm going to highlight a couple things on the RiverStone side and then go through a couple of the combined metrics on the combined statements. And so just on the RiverStone side, a few things to point out on the balance sheet. Cash, we're at about 16 million at the end of December. This is an increase of $4 million from December of 2024. We had a spike in our cash balances in December, which is normal cyclical for us as we collect half of our property tax money in December. So we half in June and half in December. So a cyclical increase in the mill levy money that we collected in December was about 1.9 million, a little bit over 1.9 million. So we saw days cash on hand spike in the month of December to 83.76 days. So really close to that 84-day goal for the fiscal year. I do expect we'll see a little bit of a decrease in that as we start the beginning of the calendar year, just normal operating expenses until we get to the second mill levy payment in June. But I feel really confident that we'll meet that 84 goal by June of this year. So of the cash balance of the 16 million, about 13.2 of that is unrestricted. And like I said, that days cash on hand, the increase, just to put it in context, from December of 24, it was at 49. We increased from 49.27. So an increase of 34.49 days over the last calendar year in that days cash on hand. On the statement of revenue and expenditures, we ended the month of December with a revenue of about 368,000 compared to a budget of about negative 99,000. As John mentioned a little bit during his presentations, this is largely driven by vacancy savings, so salary and benefit variance. For the month of December, salary and benefits were under budget about $328,000. So really making up that variance in the bottom line is that combined with about $161,000 in variance in patient services revenue, largely driven by the 340B program. So those two variances really make up the bottom line amount of $368,000 for the month. For the first 6 months of the fiscal year, so year to date, bottom line, we're at about 1.9 million for the RiverStone Health side of the organization compared to a budget of about break even. Again, largely driven by salary and benefit variance. So of that amount, that bottom line of 1.9 million was a variance of a little bit over $1.4 million in salary and benefits from vacancies. At the end of December for FTEs for the organization, we were at 326 FTEs compared to a budget of about 353. So that really is driving that salary and benefits amount. Any questions on the RiverStone Health side of financials? I just want to touch on a few things on the combined financials.
One question on that number of full-time equivalents. That's down about 100 people or FTEs or however you want to put it. That's down about 100 from a couple of years ago.
Yeah.
We have, and this is probably more a question for John, I think, but Shannon as well. Do we have any estimates on, given all of our programs, how many FTEs we should have to be fully staffed?
We've actually done some analysis on that, really specifically as it relates to the clinic side of the organization. I think, really that number that we're probably thinking of is like total bodies, not like the full FTEs. And so putting it in context, it probably isn't 100 different. I mean, because that was probably looking at actual individuals, not just people that are working full time for the organization. But I think the other thing to put in context is we've gotten rid of some programs too, like the hospice house had quite a few FTEs associated with it. But I mean, all that to be said, like we are not at full capacity for staffing. So that I can't remember. Do you remember the number on that analysis for the side? Yeah, I can't remember.
Exploded off the top.
Yeah, I don't want to put it either. I'll get it wrong. But yeah, I think we obviously recognize that we aren't at full capacity for staffing. And so as we go into budget for next fiscal year, also taking a look at that. but also taking a look at our individual, our current staff. You know, I mean, one of the biggest things that will come into play for next year's budget is getting staff increases done. And so we have weighing, right, adding those positions back in with increasing the current staff we do have. And so just, I mean, we'll do the best we can to do all the things, but that's a priority for us first and foremost, and then adding the positions in following that.
So if you look at page 80 on the RiverStone Health Financial Report, there's a dashboard there that indicates our budgeted FTEs was 353. We're sitting 326. So from a budget standpoint, is that about 28 employees short of what our budgeted staffing level is.
I think about it also from the perspective of if we're grossly understaffed, the stress on the staff making up the difference for those persons that are not on board. Got to be stressful for the staff.
Absolutely. Yep. We recognize it daily. And part of it's recruiting and retaining staff too, right? I mean, we do have the position posted as, onboarding and getting the right staff into here. But as we go into budgeting, obviously we sit down with the program and look at staffing needs and, that's the biggest piece of our budget. So we work around that, getting all the salary and benefits in and then adding the other pieces in. But yeah, no, we absolutely recognize it's been a decrease over the last couple of years.
But the numbers look great.
It does help the bottom line.
It does, yeah, that's the give and take. It's like, we need to right size the organization and help those folks that are out there busting their butts to, maintain a feasible workload. And so one of the biggest problems that we've had over the year, and I wouldn't call it a problem, but it's a new trend in healthcare workforce right now, is the ability to recruit and retain the right hire and the right fit. And I didn't have it ready for this month, but I'll make a note to bring it to next month at the more in-depth look at turnover. And as we've seen turnover kind of creep up a little bit, the majority of that turnover has been in staff here less than a year, or in less than 2 years. So we have been hiring, try to fill vacancies and get folks in the door. But it's the diagnosis is that we haven't been hiring right. And we haven't been getting the right fit and the right employee in the door, rather than just getting the body in to try to support and take some pressure off of our staff. And it's
got to be expensive to have somebody who you're doing and then.
Yeah, and so that's the issue that we're seeing and healthcare is seeing across the state and the country right now. How do we get the right people in the door with the right qualifications, but also the right fit?
I'd just add with that even though that we do have some pockets where there is higher turnover, overall, relative to other healthcare systems, our turnover is very, very low. Half, if not more, than what other healthcare entities experience.
Yeah, our trend in culture and workforce continues to outpace the industry for sure. And we talked about that last month. The industry average was 30 something, and we may have creeped up to 14-15%. So we're still well within our means of maintaining the culture that we have and keeping people on board.
It'll be interesting to see the analysis, John, when you break it down.
Yeah.
Does it tend toward administrative areas or patient care areas? I would think, being a naive administrative guy, that you would be able to anticipate what a patient care job will be like more easily than the administrative. If you're going into direct patient care. And again, that is certainly a naive perspective. And pole vaulting back to a comment that Spencer made and that Michael made, if we're down 20-some FTEs. Yeah, that's where the $1 million favorable variance comes from. In salaries on the financial statement, on the income statement. But then I right away looked up at the revenue, because on the caregiver side, on the clinical side, it's also where the revenue generating service is provided. And if we don't recruit and retain the hands-on caregivers in the patient care area, it causes that revenue to slide, to decrease more than what the salaries are. We've experienced that before. Other comments, Shannon? I think ready for consolidated. Is that where we were?
Yeah, I think just one more comment that I'd like to make on that we've really taken a push organizationally, like I mentioned, to look at compensation. And so we're going through each employee and really just looking at how we can do things a little differently as we budget in salary increases for the next fiscal year. So stay tuned on that as we start bringing in some preliminary budget information to the board, but just knowing that how much of a priority that is for us organizationally, especially as it relates to retaining staff members.
Maybe just a couple of high level comments, unless there's other questions for Shannon, but just an appreciation for the staff for the presentation of this. A lot of effort goes into this, and currently they're in the process of budgeting for the next fiscal year. So we're 4 months away from turning the page. Maybe this is more of a commentary, but we've been in the last 2 years been in a very much budget process of cost cutting, budget process of tightening our belt, of cost control. We're now kind of transitioning, because we've been so successful over the last 2 years in that effort, into more of a balance budgeting approach, where there are going to be some opportunities to look at some initiatives that maybe drive additional revenue or achieve some additional policy goals. So hopefully, I think in addition to that, you'll start to see perhaps some more items on our physical facilities on deferred maintenance that we kind of set aside, as we've been very conscientious of controlling costs. Certainly, it's a balanced approach. It's not it's going to be a very controlled process, but just wanted to make sure the board was aware that kind of information will be coming forward. And we're still trying to wrap our arms around the Medicaid redetermination. You look at the financial report still trailing a little bit behind our budget there, so that still remains kind of something that we have to keep an eye on. But overall, the organization is very healthy. We're achieving we're on the road to achieving the objectives we set out at the start of this fiscal year. So very pleased about that. Any other questions or comments? All right, Jen, turn it back to you.
Just a couple of things to highlight on the combined YHP and RiverStone Health statements for the second fiscal year. For current assets, we're about 3.1 million at the end of December on the YHP side. We continue to have that account earmarked from the sale of the hospice accounts, and so that's set aside separately if you're following along with the balance sheet. But proceeds of that are about close to 1.7 million held in that separate account. The most important thing to probably point out as it relates to the combined financials are the debt covenant days on cash on hand ratio. And so that's calculated a little bit differently than we're calculating the RiverStone Health days cash on hand ratio. But when we combine both of those entities together and look at that amount, we're at 161.63 days at the end of December. For context, we were at 72.78 days in December of last year. And more important context, our debt covenants indicate 60 days. So we're well above where we need to be for our debt covenants. We only report on that once a year in June of each fiscal year. But that's a great place to be rather than being worried about that number as it relates to the bond.
That's phenomenal. I mean, congratulations, John, you, staff and everything. I mean, what a significant turnaround in 2 years. So congratulations. Very admirable.
Michael?
I I was looking at some of the, while going through all the financials, and I'm looking at this one here, RiverStone Health Financial Report. And there's a couple of boxes there. Two green boxes that always strikes me as yipping. And then there's one in
page are you on?
and then there's one,
What page are you on? 77.
77, yeah.
and then there's one in red, and I'm a bit of a pessimist, so I always go to the red, and its goal is 84.
Yep.
And we're actually 83.76, and that gets red. So wait a minute, I'm thinking we need another color, probably yellow.
We
for those-
can't, we tried.
We tried a light red. What if you rounded up?
We tried. The limitations of our technology prohibit us from.
If my memory serves me correct, in finance, we assessed the specific scenario.
Yeah.
What is Michael gonna do when he? We decided it's okay if the board sees red numbers occasionally.
So Spencer, you prepare for the gadfly?
The gap.
Oh, goodness.
Other comments or questions? Can I get the omnibus approval motion to accept the February 26th committee meeting notes, the December RiverStone financials, the December YHP financials, and the second quarter consolidated?
So moved. Second.
Any other comments or questions? Hearing none, all in favor? Opposed,
Aye.
same sign. They are accepted. Any old business to come before the board this morning? Any new business to come before the board this morning?
Project update.
So I think that's me.
Yeah.
Should can I come up or should I be?
You can. come.
Okay, all right. Hi, everybody.
Who has your day?
I gave it to Carrie. And if I don't have to.
I'll put it up, don't worry.
Okay, thank you.
Yep.
Hi, everybody. My name is Kelly Amade, and I am the Director of Organizational Innovation. And I'm really excited to come talk to you guys about projects. So what we've been doing over the past year and what we're going to be doing over the next year to make our organization better, our continuous improvement. So as we're kind of waiting for the slides, I'm going to talk about projects that we have done and projects that we are going to do, but we have a lot. And I know that I only have about 20 minutes to talk. And if you gave me the time, I would talk to you guys all day about these projects.
I will give you 40 minutes this morning.
Okay, you're going to get, okay.
You're
Oh,
welcome.
wow. Okay, well, in that case, I will go.
And everyone, bring we have.
As I go through, I do want to, don't want to hear about projects? I'm just. No, I'm just like. Okay. What?
I got it. I'm just trying to figure out the tech. Sorry.
No worries. I'll actually just maybe just start talking about them. I
Yep.
did organize them in our strategy in the HELP. That said, some of these could span between a couple different, so it's interesting to know what we're doing. So, oh, awesome. Thank you so much. I'm just going to start listing them off a little bit and talking about them. I want you guys to please feel free to interrupt me with any questions that you may have about the projects as I talk about them. So we'll kind of start with H for health. We've added a couple different services within our clinic, which is exciting. Spirometry, which is a breathing test that helps identify COPD and asthma and other types of breathing issues. It's actually something that we used to do here at RiverStone, but stopped doing it, I believe, due to staffing issues. And so we got that up and going again. Same with EKGs. The EKGs, we had an EKG machine, but it was relatively unfriendly to use. Our staff was not pleased with our EKG machine, so we upgraded, upgraded. And now our EKG machine is actually integrated into our EMR, our ECW system. which is exciting. And we've got good staff satisfaction on that one. They actually are really wanting more of these EKGs, and so that's exciting. We also stood up better televisits. So this is the digital online visits that we can have with patients can have with their providers. We upgraded the system from, I believe we were using Zoom, and moving away from Zoom into our Teams platform and utilizing our ECW as well for that one. Another upgrade to our ECW system is online scheduling. This one is really exciting to me. This is actually something that was a push from Eric, which was great, is to be able for our patients to schedule online for clinic visits. It started small with just our same day care visits, and then we expanded to all of the not continuum, continuity, sorry, of patients as well. There is plans in the future for our specialty clinics to get online scheduling as well. I think this is exciting because I know that Intermountain has been doing it since they've merged to become Intermountain, but I know that I used to work at Billings Clinic and that was a push on theirs, and they still haven't. I think they're only on same day care. So I think that's very exciting and great for RiverStone Health. I've actually, as an anecdotal story, I have a friend who's got a young adult son. So he's 19, just learning how to make his own appointments. And now that we have online scheduling, he's coming here for that. So, which is great. Also, our Joliet relocation happened last year. That, as you probably all very well aware, having to move out of the one location we had in Joliet to a temporary space. And that was very successful. Got us into that new space so we can see patients. In education, NEO stands for New Employee Orientation. This we revamped our new employee orientation. It was a kind of a discombobulated system where people would come for the first couple of days to get some orientation, and then within the next couple months, they got 5 full days of another type of orientation, kind of a cultural orientation. And that we found was a lot of time that new employees were spending doing that, and then also having to wait a little bit for that cultural orientation was slowing people down from kind of really getting into their positions and understanding what they're doing. So what we did was revamped it, and now it is a 3-day. Right when they come, their first days are here. When their first days are here, they start with our HR orientation, and then we do cultural orientation as well. And then they're off and running when they're done with orientation. ECW upgrades. So you'll actually see ECW upgrades and optimization as a kind of a continuous project that we're doing here. So we are a continuous improvement organization, and when it comes to our ECW, which is eClinical Works, is our EMR or electronic medical record, we've got a kind of a history of maybe not taking care of it the way that we should have, and so it's a little bit of I don't want to say it's a mess per se, but it's not necessarily organized in a way that provides for a proper upgrades and the proper use of the actual system. So we just did a strategy meeting where we set out until 2027 the upgrades that we want to make to ECW and the projects that it's going to take to do that. So we did a lot of ECW upgrades last year, including training modernization. So we have an amazing staff member named Shelby. I'm drawing a blank on her last name right now, Traeger. And she is our trainer for ECW for our EMR. And with her amazing skills, they have revamped the way that we orient people to the EMR. And it's really been successful in getting people really understanding the program and the system before they're asked to be charting in it and using it. So it's, again, an improvement to our new employee orientation for that. Under leadership, our wellness on wheels, that was a big one last year. And the garage, which we I didn't put it up here, but I want to know that we lovingly call it the bus barn is how we refer to it. So that was a big project, getting that WOW up and going, getting the medical visits. And that is actually going very well. Also, standing up the senior high clinic in the senior high school. That was really great. Both the WOW Garage, senior high clinic, and actually another one I'm going to talk to about really does set us up too for the rural health transformation initiative that's kind of coming out. Really, there's that school-based health system track in there, and these really kind of set us up with good, for lack of a better word, recipes for how to do these projects, how to stand up clinics, how to move clinics so that we can do them more efficiently every time. Under protection for our immunization clinic, as I mentioned, we did online scheduling for clinic, but Immunes was actually, I should have mentioned this first ones that we did. So they're kind of almost the pilot, if you will. So standing them up to have those online scheduling. And then finally, we just kind of finished this up, and actually, to be frank, it's not quite closed yet, but our move of the home healthcare for the homeless clinic to our Montana Rescue Mission location. So that happened just a couple of weeks ago. That is very successful. They love their new space. It is I hope maybe all of you got to see it at the open house. I hope that some of you made it to it. But it's a really great space where we can really serve that population in ways that they deserve. So what's coming next? If you don't mind moving to the next one.
I have a question.
Yeah, please.
Yeah. So, when you're doing these projects, is there like a formal business plan that you put together that with, like what you hope to accomplish, the financial parameters?
Absolutely. So it's called a project charter. And so that is something that we have a standard form, form right here at RiverStone to do that.
So then so these are all complete. Who monitors them afterwards to make sure to see if you are meeting the goals?
Yes, absolutely. So that is something that it's me. I haven't done as well we haven't had many financial or process improvement projects where we do need to monitor those for a year. So we do have a plan for those that we monitor for a year afterwards. So, and that can be depending on the data. So that could mean monthly that we check on things, or if it's something that maybe data only comes in every couple months, every quarter, every 6 months, something like that, then we would check in during those times. But yes, absolutely. That's part of that Lean Six Sigma to make sure that there's a control that we don't slip right back to where we are going to go. Yes, absolutely. And he's not, never mind. I was going to say if we could go back to it, but no, you're fine.
Nose is running.
No. So for example, not a lot of these were improvements to something else where we're watching it. So like spirometry, for example, we're just new patients that we're seeing. And in fact, that one, we are adding a whole other second day. We're doing just 1 day a month. Now we're doing 2. But yes, I really appreciate the control part and needing to make sure that we keep on track of that. And actually I'm so sorry, I don't mean to be bossing you around so much, but do you mind going to the next one?
Before you jump there, just for context, the project management office is new to the organization in that we manage these large scale projects as an organization-wide initiative. And so when Kelly, who recently got her PMP, so for those of you that don't know,
my thunder.
We brought Kelly on with the intent that we would continue to evolve that process. So a lot of the questions you are asking are on our foundational growth platform, but we're not there all the way, including the systems to manage projects. But your points are all very well taken. As you're going through projects, you need to know when the project team hands it off to Eric, for example, You've already had discussions about what that handoff looks like. What are the KPIs that Eric is going to be watching as it goes forward, just to make sure that as an organization, we've invested the dollars and we got the return on those dollars and human resources that we anticipated. So I think more and more you'll see Kelly come to this group and share some of those insights and information. But really, I just want to stress that we're a little bit fledgling in this, in the way that we look at projects and prioritize them against our strategy and our budget. But more to come. It's pretty exciting stuff what the team has already been able to do.
Yes, I did strategy and business development at one point in my career. And one of the things we were really bad at was looking back to see if it really worked.
Yeah.
And then having an exit strategy if it didn't work. So,
Yeah. Actually, that's really a great.
yeah, that's the hard part.
Yeah, absolutely. I agree. And how projects go is like the next one's lining right back up.
Sure.
So you've got to,
Yeah,
you've got to be,
moving on and.
you've got to be dedicated and make sure that you.
And to this coming Tuesday, we're gonna have all of our senior directors in a room and have that similar conversation in KPI development and monitoring and tracking performance across their departments and how that relates to strategy development and our strategic roadmap that we've outlined and shared with the board on now, how does this relate to me and my individual department or my individual project, and what are we doing? And I don't want to appreciate Kelly's PMP, so that's a round of applause. Thank you. And we're fortunate to have that asset in-house, and we're deliberate about developing that and bringing Kelly on board and wanting to create this office. It is, as I talk to colleagues across the state and the nation, it is a high demand role now. And especially with rural health transformation dollars coming and some of these other things coming down the pipe, we did this deliberately and intentionally so that we would be prepared for things like this, so that we would know how to roll projects out and manage things over time. So we've got to get better, but we're well on our way compared to some of our other competitors or compatriots.
Do want to make it first. Oh, go ahead. Sorry.
PNP, I'm sorry.
PMP. It's a project management practitioner.
Project management. Okay.
So it just means that I've got trained on how to do good project management.
It's a professional role, so she has to take an exam that is fairly extensive and pass that exam to get that certification.
Okay.
The organization saw the potential there. We were glad to invest in Kelly to get that certification. And as John mentioned, you're going to start to really see the return on having an asset like that within RiverStone Health.
Got it. Kelly is also a major player in our safety and quality committee. It makes sense, given what that's also part of your responsibilities. And it's fabulous for that committee, just so everyone knows.
Thank you so much. Yeah. And I am, not to make this kind of personal, but I am really, the business part of it, you guys invested in me, and but I am actually personally very excited to make changes to the program. When I was building this, I felt like I wasn't bringing enough to you. KPIs, I wanted financials, and we're growing to get there, but that is my hope for the future, is to have a little bit more meat when I come and visit you with you guys about the projects. Which kind of adds to one of the projects that we are going to do next year, or we're currently actually in the middle of doing it, is ERP planning. So enterprise resource planning, which is kind of funny. In the sense that the ERP is a software system that spans a lot of departments, but really the heart of it is within our financial system. So upgrading our financial system, not to be a downer, but our current financial system is right now our only out of date, out of compliance software system. So it is something that we really need to upgrade. So an ERP not only does that fiscal side, but has HR modules that has, excitingly for me, it has project modules, asset modules, just a lot of things for resource planning. Obviously, that's right in the name. So that is a project that where the planning project part of the project is almost complete. We are writing, we've written an RFP for us to explore the options of ERPs.
I had a question for you, Mickey, can you tell your, are we server based or like AWS, or where do we stand as an organization? I would assume with ERP, that would be looking to go like AWS or something to that degree.
So most all of our newer systems are cloud-based.
Okay.
For all of the usual reasons, right? Maintenance, resiliency, performance, just cost of ownership. When you're buying servers and manning a server room, it is just really expensive. So we do have some remaining assets that are upstairs on the 3rd floor in our server room. But the long-term plan is we will move all of that to the cloud. What we'll keep on site will just be a redundant backup of key databases and files that we need if we lost connectivity to the internet. But yes, long-term, Steve, everything is going to the cloud.
Actually, it's like you're teeing me up. It's perfect.
Well, you teed me up with the.
So one of our other projects that is currently in flight and is a doozy of a project is this data classification, which actually speaks to that. So the precipice to start this project was for those legacy systems that are still on the 3rd floor in that very expensively air-conditioned room, is to move off of those. SharePoint 2016 is one of them in which we store a lot of data on. It's actually being sunset in September of this year. So we need to move off of there or else we're going to lose our data. And so that's really what started it. But it's more than that. Once we realized that we need to move some data, we recognize how, again, I keep using this word, messy our data really is, where it's stored, how it's stored, who has access to it, just basic, data hygiene, which is a new concept a little bit in this age. Yeah. So that project is it's very large in the sense that not only are we moving this data from the legacy systems into the cloud-based systems, but we are helping departments reorganize that data so that we are organizing it in a way that makes sense, that is safe, make sure that we have least access privilege, meaning that that just not everyone has access to everything. They have access to what they need to do their work, and no more.
The last benefit there, which is somewhat new, is we're structuring it in such a way that our AI tools allow us to quickly access information top to bottom, compile it in ways that are more meaningful to the organization. So when you think about using data to make decisions, all of this pre-work is just to get us to the point where we're able to use the newer technologies to help us move more quickly.
That new functionality, which is very exciting. Okay, the rest of the projects. Peer support team. This one is very exciting. This is also been known as the HOT team, that currently is housed under Rimrock. Excuse me, I couldn't write. RiverStone is so close to Rimrock that sometimes I forget Rimrock Foundation. But they're no longer going to be able to support that team. So they're moving here with us and with our healthcare for the homeless team. So that is really exciting. That is something that's going to kick off here in March. Electronic check-in for clinic. This is another ECW upgrade. This is really great in the sense that if any of you, well, hopefully all of you have been to a doctor before, and that when you first check in, there's a lot of paperwork that has to be signed. We're actually going to, or filled out and signed, with electronic check-in, is that we can send that information to patients before they come. And so they can sign, do all that administrative work. And so that when they get here, we can just get them signed in and ready, or excuse me, checked in and ready to go. Under education, the clinic scheduling solution. This is a little confusing. It is not the online scheduling solution. This is the back end scheduling solution. So right now, or current state, we have 2 amazing women that do the entire schedule for our MFMR residents, for our MFMR faculty, for our RiverStone Health faculty, for our RiverStone Health APPs, and for our MAs and nurses, which is a lot of people and a lot of moving parts. They're amazing and they've done a great job, but they are bottlenecks, if you will. God forbid they win the lottery and move to Bali, we lose a lot of knowledge base. And so this project actually is bringing on a new software that takes all what's in their amazing brains and puts it into the computer so that the schedule can be done quickly. They're basically writing the rules. And so that all they have to do is plug in the names and bam, on the other end, we have the schedule is done. This is amazing, is that it is going to free up those women. I'm saying that, well, there are 2 women, but those people to do other things for those programs as well. So this is going to be a really great savings, soft savings.
I would assume my wife did that as the employees that can actually log into it and see their schedule and adjust it from there.
They can swap and they can, yes, it's so great. Yeah, it takes a lot of work out of the manual space there. It's really fantastic. ERP planning we talked about already. The next 2, I'm so excited about all of these. I feel like I could talk forever about them. But MA training program and our APP training program or residency. So for our MAs, as you guys well are aware, that is a tough position to fill. It is a skilled position, but is also entry level as well, right? So it is, and we have kind of a high turnover in our MAs. This has been another issue of, are we hiring the right people? Do we have the experience when we need it? And the pool of candidates isn't exactly the quality for which that we want for our patients. And so the MA training and certification program will actually give just or they don't have to be new graduates, anyone that's interested in becoming an MA. They come in here and we will help train them and get them certified as well. So this is kind of an on-the-job training. They will, in the beginning, not be doing a lot of patient care, but then of course, increasing their patient care over the year as they're learning their skills. And then we will pay for them to get their certification as well. So we will have certified MAs for our staffing of MAs, which is very exciting. The APP residency is somewhat similar in the sense that we are getting a lot of very new, and I'm sorry, APPs is advanced practice practitioners. They are our nurse practitioners and our physician assistants. Same thing is that we're getting very fresh graduates as candidates for roles, and we're already spending about a year training them. And so by formalizing this as a residency program, not only can we cover some of the costs, but really make sure that we are training these new graduates into the way of doing a PCMHC, a CHC, how we can do, how we do patient care here. So that's a really exciting one that we just started getting applications for this residency. It should start in the fall of this year. As you see, ECW optimization is still on that list. This one, actually, I have a whole other separate list that is all ECW optimization changes. The major ones that are exciting for our patients, I've already put in there, like electronic check-in for clinic. There is another, the portal. So how do I explain this? The portal,
Patient portal.
Patient portal, thank you. Just patient portal where patients can go in and check their labs. They can actually do a lot of things they can schedule on there. We are going to do some modernization of that so that there can be better back and forth between the care team and the patient, and that the patient can utilize that portal for more things. Not only that, though, there is a lot of internal charting and organizational initiatives going on for ECW optimization as well, so that we're charting correct ways that staff and providers are able to find what they need to find right away, and there's less clicks as they have to.
Will it also include billing for the client? So in other words, I go onto the portal and look at my billing and pay for it at that time?
I think, yes, that's gonna be part of the modernization and I believe you can already.
Yes.
Yeah, yeah,
Yeah, and we've seen some pretty good
yeah, I actually.
return on that investment. So
You
you
talking, I
I was gonna say,
can,
yes.
then you can have your text to pay.
Right.
So like we'll text you an update, or you can log on to the portal, pay your bill there. I mean, that's how my generation does its business.
Right.
And so
Exactly.
it's able to get those folks who want to pay that way on board. You don't have to come here with a written check and or mail it in.
Actually, my favorite part, my dentist still requires me to write a check and it's the worst. So I paid many a bill here.
You may need a younger dentist.
I feel.
Retirement may be coming up. I do have a question though with the portal and all the pre-service stuff that you do, you know, to get checked in.
Yes.
And then following up on results, can you monitor how frequently that is being used?
Yes, there's a lot of analytics on the back end that are really exciting so that we can recognize, if it's being used, we're kind of using that a little bit for online scheduling to see who is online scheduling, what are they scheduling for, are they scheduling appropriately? So there is that back end analytics that we can do.
The goal is to continue to add more and more of the appealing capabilities to the portal that drive the adoption up. So when we add a new capability, the first place it's going to go is into the portal. Doesn't mean we can't do things the old fashioned way, but we certainly want to encourage the electronic ways first.
Can you tell, hypothetically, do you know how many people are registering through the portal?
We'll be able to. So right now,
Okay.
yeah. Yeah, there's it's report. We've got a good, our data analytics team is great. And so, yeah.
Thanks.
Kelly, can I give a couple of the numbers? Really quick?
Awesome.
Yep. So for just context, for the text to pay campaign for January 16th through January 31st, we received 246 payments through that, which is a little over $20,000. 163 were made through the text link, and then 83 were made through the portal. And then the next 2 weeks, February 1st to the 15th, we received 230 payments, was about $17,000. 146 were made through the text link, and 84 were made through the portal. It's been pretty significant.
And we've really focused heavily on the patient experience. Not that there's not a lot of work going on in the back end that help our clinicians and the operations of the clinics, but we recognize that we are a little behind on the patient facing features. So you'll see that through the next year or two that we're focused there, so that one example coming up is that we used to manually make all the payment arrangements. If someone couldn't pay their entire bill up front, we had a person that would sit down and draw it out. Well, now to kind of the question about what can I do online with payments, we're working on the systems capabilities that allow Steve to come in and say, I can't pay everything today, but I could do this. So again, trying to provide that, I'll call it a little bit of a kiosk treatment through electronic means.
That's great to give them payment options.
Yep.
The payments coming in ACH or is it just credit card?
A credit card or just direct transfer from a bank account, like a debit.
Okay.
Yeah.
The last here in education is employee engagement. There's a couple things that have to do with employee engagement, but for example, the employee engagement survey. So understanding how our staff feel. And then also there's an initiative for basically project creation, but not large scale projects. This would be if someone's got an idea within their own department, how do they bring that up? How do they make change that they would like to see in their area? And right now we don't really have a great standardized avenue for them to do that. So we are creating that avenue so that everyone is active and engaged in making continuous improvements in their area. Under leadership, we've got, so the WOW is still in play here. As you know, maybe you don't know, in the very beginning, what we really want to do with the WOW, our Wellness on Wheels, is have it to be a well-rounded service so that we would have medical, dental, and behavioral health. And so we are working now on the dental side of getting them onto the Wellness on Wheels. This one we've hit a little bit of a snag. This one is in the red status, that we don't have the right funding for this one. We are looking for funding, fortunately or unfortunately, I guess. The instruments that dental needs for the bus are relatively expensive. I would like to shout out to Gail Young, the manager of dental. She found just through her contacts, there was a dental office closing. And so she was able to save about $20,000 worth of money for instruments. So we've already got some instruments, but we do need some money to get the rest of them. So once we are working with our new grants manager to find those funds and get them on the bus. So
If anybody wants to write an $80,000 check.
Yeah.
Or it's 5 or 10 each, you can have it this morning.
yeah,
Yeah, it's got an $80,000 bogey to be able to fund dental. And then, once we have that equipment on deck, we've got a dentist already scheduled who will be here on Fridays to go out with a mobile unit and see patients. But it's the equipment. We've got everything else in play. We just need to equip it.
Exactly. And the staff is really excited. We've worked on workflows within the bus, and it's an exciting concept to be able to go on a mobile unit and provide services. And so they're very excited about that. Another this one's more sequestered just here in the LAC, the Lil Anderson Center. We are working to make this building a little bit more friendly to our public folks that are coming in for services here. So right now, one of our busiest locations or departments is EHS, Environmental Health Services, and they're up on the 4th floor. So that requires our clients to do a lot of movement to get up there. So what we're trying to do is move the departments that have more front-facing client work down further in the building, and move more administrative up. This is quite the Shelby. And it's significantly more complicated than you would think it would be. So we are working on that. And so you'll probably notice some changes. One big change is that we will be opening up that front door. So we'll no longer be locked, that you don't have to buzz to come in, that it'll be opened up, which is very exciting. More friendly to the public. And then finally, the last one I haven't talked about yet is our EHS system update. So actually it was perfect because we were just talking about EHS. So their software system that they're using, actually the state is buying a large repository, system, and we are joining in on that. And so we did pay a little into it, but the state is paying for a significant chunk of it. And this is not only going to upgrade the system for which they work and to make things a lot easier for the sanitarians and techs that go out and do the work, but also, I'm sorry, I forgot my last second point until just now, is that it opens up the data for the entire state so that there can be better collaboration between entities. We'll have them all in one place. Okay, actually, I did okay. I cut a little longer, but any other questions? Yes, sir.
Just a comment. The board has seen many of these things, but to see it all from the perspective of health education, leadership, protection, and organizational improvement, to see it put together this way is really helpful.
Awesome, great.
This is really very helpful. Thank you, Kelly.
You're welcome. And I did want to, just because I can't keep talking, just real quick, these are our major projects. These are the ones that are huge. They're on this list, but there are a lot of little things that we're doing as well to make continuous improvement, helping out with the service area competition grant, the SAC grant. Wasn't necessarily a huge project, but we put it together in a project format so that we could keep organized and so that we, stay organized during the whole thing. So.
And if any of you would like the info on our slides, I have it down and I can send it to you.
Other comments or questions?
Yes.
With the data, with the update with the electronic health system,
Yes.
what does it go into like Epic or Cerner, or is it just the state?
Just the state, yeah. So no, there's not, for EHS, there's actually no patient information in there. It's not an electronic medical record.
Oh,
That is where they do the inspections on tattoos, on pools, on restaurants.
oh,
So all that data, that is what that's for. Yep.
That's GovTech, but our ECW, our electronic health record, we are connected with Big Sky Care Connect. And so everything that we do is visible up the street and vice versa. Everything that they do is visible down here.
that's cool.
One, because our residents and faculty have access to Epic or Cerner, but two, because we're on Big Sky Care Connect HIE infrastructure, we are sharing that data across the state. Sorry, Bob. Was that?
No, that's great. Yeah. Other questions for Kelly? Comments about the presentation? Thank you very much.
Thank you so much. Thanks for letting me come talk to you.
Nice job.
Thanks. Go.
Anything else to come before the board this morning?
I'd like